Welcome to the Dr. Paul Show. I have the pleasure of introducing a dear patient of mine I've known for almost 20 years. So long, actually, that I was her primary care doctor before I started doing what I do now full time. So that is a long time ago because um, I've, I've switched my practice over to psychiatry for a long time. But I want to talk today about bipolar disorder. It's a subject that's near and dear to my heart. I love this subject. I could talk endlessly about it. I'll try to not bore you. But it's something that's very impacting to patients. And so, anyway, Kristen, welcome to the show,
Thank you.
and great to have you here.
I love being here. I love the subject.
Thanks. I do too. So tell us about. I heard you read the book.
I did. It was awesome.
You liked it.
Liked it a lot.
Oh, good. Yeah, I loved writing it. I think the bipolar chapter is one of my favorites. But yeah, it took me a long time to write this book, and basically the book is it's 30 original short stories that I tell about people. Even though the title is kind of crazy with the subtitle, I talk about anxiety disorders, depression, bipolar disorder, ADD, PTSD, eating disorders, schizophrenia, narcissism, borderline personality, sociopaths and psychopaths. And then I get into the subtitle subjects: addiction, bullying, homelessness, school shooting, suicide, basically I tell stories about people, and then I go into my story, what got me into this, and I talk about the good, the bad, the ugly, with what happened with me, and anyway, it was a book that I really am proud of. I loved. I enjoyed writing it. It was a lot of work, but I
Hmm.
think the results have been good, and I'm really happy with what I'm hearing about it. So thank you for reading it and
It was great.
enjoying it. So enough about me, more about you. So tell me about your story, if you can.
Okay, I'll start back when you were my primary care physician. Um, and then you changed over to basically psychiatry. And I was diagnosed with GAD, generalized anxiety disorder, and you put me on gabapentin, which helped. Um, and then we realized I had bipolar, and I just want to read something from the book that makes me a little bit understanding it. It says hypomania, on the other hand, is a milder form of mania featuring rapid thinking, frequent insomnia, and reduced need for sleep. Hypomaniacs individuals lack the paranoia and irresponsible, whatever it says, seen in full-blown mania, and can often maintain highly functionality, and that was me to a
That,
T.
that was
Yeah,
so you weren't getting like the
no,
paranoia, the irrational thinking.
no,
Yeah. So to the listener, so bipolar one disorder is the one that people think most about. That's when people get really highly irrational, paranoid, start spending way too much money, start having indiscretions sexually, get hyper religious. Anyway, they just go kind of way off the rails. Bipolar 2, which you have, is actually a milder form, and a lot of doctors miss it. A lot of doctors think of it as only anxiety, when it's actually a different. It's hypomania is, like you said, much more functional. You don't need much sleep when you have hypomania, and people function actually, and a lot of people say they function actually really well on with hypomania. The problem is it doesn't last, and then people just kind of crash into depression
yeah,
eventually. Is that what happened with you?
yes, that's exactly what happened.
Yeah. So describe that. Describe when the early journey through bipolar and discovering that, and what happened then.
Well, I always knew I had mania, just not the realized now it was hypermania because I would work for every day for 12 hours and I just nonstop. And then one day I felt like this sadness and realized it was depression. And then I talked to you about it, and that's where we got the diagnosis. I also want to add there's a chapter in here for addiction, and I'm an alcoholic in recovery. I've been sober for 13 years, and I think that could have brought on some of the depression because I'm drinking.
It's the chicken or the egg. It's, you're drinking to help your stress and feel better, but that's part of it. And then the other part is that So drinking is masking it, but also the underlying mood disorder kind of drives you to drink, and so it's like it's one thing leads to the other. It's back
Okay.
and forth, and so so it can be a really vicious cycle. But yeah, the addiction is extremely common with all variations of bipolar,
Okay.
and then also you get into bipolar depression, which can be a really dark depression. Have you experienced
No,
that?
thank goodness no.
Good, good. Yeah, you're on a really good combo. You're on gabapentin, Topamax, Lamictal, and Seroquel, right?
Yes, and about 10 years ago, I moved to Palm Springs, and my primary care physician took me off Lamictal and said, "You are not bipolar." So I've suffered because of that.
Yeah. Unfortunately, what I see a lot is when I get the meds just so everything's perfect, everything's great. You people go to their other doctors, usually primary care doctors, and they say, "What are you doing? Why are you on four things? That doesn't make any sense." And what they do is I don't mess with their medications.
Right.
Okay, so if they have you on a blood pressure medication or whatever, cholesterol, diabetes, thyroid, I never touch their medications.
Yeah.
I never think about that because it's not what I do. It's what I did do. I used to do that, but I don't do it anymore. But it's amazing how many doctors want to mess with what I do,
Yeah.
and they don't know anything about you, your history, why I put you on Lamictal, but they take things away. They you don't need that. Well, how do you know that you didn't need that? Well,
Right.
I just look at the list there, and it's just like four is too much. I think you should only be on two or three things. Really, really common that happens.
Yeah.
It happens all the time. And it happened to someone today actually in my practice and the problem is then when the doctor says that, the patient might be, let's say, like, well, man, maybe he's right. I don't want to be on so many medications. Why? How long do I have to be on these medications
Yeah.
now? So the problem is when other doctors get in mess with my stuff. And people, it's kind of like, if a doctor, an oncologist is giving a chemotherapy, or would I ever question anything? I think, of course not.
Yeah.
I'm not an
Yeah.
oncologist. I don't know what I'm doing
Yeah.
there. So it's amazing. But when it comes to psychiatry, people just don't really understand.
Yeah.
And this is again why I'm very driven to teach. After I finished, before I actually finished this book, I wrote two books for doctors, and I want to actually teach. And so I've written two books I want to focus on primary care doctors, nurse practitioners, and physician assistants. I think the three groups of people that I think really can use more training. Because as a primary care doctor myself, I did get training in psychiatry, but not a lot, not as much as a psychiatrist would. So a lot of with myself was a lot of self training, reading textbooks, journals, just going to lectures. So a lot of self learning, with doing what I do, but I think that what I really want to do is teach, and so I wrote two books. One is called the Corona Protocol, Prescriber's Guide, and the other one's called the Corona Protocol: 3 Secrets to Success. And I want to actually teach online. I want to do an online course. And what my idea is actually to take real patients, and then to volunteer to be seen by me and a bunch of other doctors online, present a case and the history, and then we all talk about it. And then we say, okay, what do you want to do here? Let's think about ideas, and then we do something, and then we have the person come back in 2 weeks, 4 weeks. And so just like I did with the book, with the case studies that's how I want to teach. And I think that's going to be a very effective way of teaching. I've never heard of it before. I don't think it's ever been done before like that. But that's my idea, and it's what's driven me to want to do that is the frustration I've seen over the years of doctors just not getting it. And doctors, what they do and what they do with pretty much every patient is they think that SSRI is the best. And I don't know if you've ever tried it.
We did, yes.
And it probably didn't go well.
It didn't. It did not.
Yeah. So everyone puts people on Lexapro or Zoloft, and if you're bipolar, it makes you worse.
Okay.
But they don't really distinguish that. So they say, oh, you have a mood issue. Here's Lexapro, and not that it's a terrible medication for everybody, It's a good medication. I have a lot of people on it, but it's not the best medication for certain people. And
Isn't it for depression?
it's for depression, and it can help with anxiety. And there are some people with bipolar who can take it, but a lot of people, if you take the wrong antidepressant, you get worse, and it makes you more anxious, and then you get more hypomanic or manic. And so that's why Lamictal is the safest and best one for bipolar depression. And it's a stabilizer, so it works along with your gabapentin, with your Topamax, and it works along with the other three, the Topamax, gabapentin, and Lamictal, and then you take Seroquel, right?
Correct.
Right. So that's a great mix, if I have to say myself. So,
Well, I like Seroquel because it helps me go to sleep.
yeah. Seroquel is amazing because the sleep quality you get from it.
Yeah.
And again, it's another mood stabilizer.
Okay.
And so with you, I kind of got that nice mix together. And I think you've been on the same combination for how many years?
10 years.
Yeah, 10 years, yeah. So, and then the other question I get all the time is, well, how long do I have to be on these things? Well, that's a conversation that's tough for people because they say, well, I mean, can I wean off of them? No. Why? Because it's a chronic problem.
Yeah.
I mean, bipolar doesn't treat itself; it never goes away.
Right.
The good news, though, is that there's worse things to have. The things that aren't treatable, or things like cancer.
Yeah.
There's better things to have, that like an infection that goes away. But on the scheme of things, it at least is treatable.
Yeah.
But the good thing about bipolar, we have great medications out. And if someone sticks with it, and then like you did, the hope is great because it's such a treatable condition. But the catch is that you have to stay with treatment, and it is long term. But again, people don't question being on a thyroid medication, being on supplements, being on a blood pressure medication, diabetes medication. No one ever questions doctors about those because they know the answer is going to be keep on it.
Yeah.
But when it comes to psychiatry and mental health, people don't take it as seriously. They think, well, there's no blood test to prove it. So how do you know? Well, you know by the results. You know by the fact that you've been stable for so long. That's how you know.
Yeah.
And then unfortunately, the only way to prove that is if someone starts taking things away. And they do it. People do it all the time. They start taking, I'll take this away, let me take that away. And all of a sudden they crash.
Yeah.
They come in to see me. They say, I go, why did you take that away? I don't know. I don't know what I was thinking. And so I said, okay, let's get back on them again. And here's why you stay on them again. And so some people just, like you, just say, it is what it is.
Yeah.
I'm sticking with it. You get it.
It works.
It works. You get it. But a lot of people don't get it. They think that it doesn't seem right to have to be on things long term.
One of the things I like about your book, excuse me, is the case studies, because then I could relate to them. And what also I related to is that you titrate up. You don't start at the highest dose. You start at the lowest dose to see if that works. And if it doesn't, then you titrate up. And I really like that.
Another mistake doctors make is they start too high. They're too aggressive. What I do with every patient, every adult, I start with a pediatric dose.
Oh.
And I no other doctor I know does those kind of things. Everyone starts with the pharmaceutical recommended starting dose. So whatever the pharmacy recommends, I don't listen to that.
Okay.
I always cut them in half or have them start low, because you just never know how sensitive someone's going to be to a medication.
Yeah.
So I start everybody low at the beginning, but then I if it's going to work, quickly. So then I titrate it. The other thing about another myth in the field is that it takes like 4 to 6 weeks for something to work. It's never been true. Everyone said, well, I have to wait a month or two. No, you don't. You know the results within 1 week to 2 at the most of any of these medications I work with. So we can go pretty quickly, but I like to start slowly and titrate until I see the results. And if we go a little bit too high and we get side effects, okay, now we back it down. Let's stay there. So it's a lot of tweaking things, titrating. Okay, let's stop there. That's the right dose. Okay, let's add some of this now. And most of what I do is putting things together and putting a package together.
So, because I don't remember, when you get, let's just take Seroquel. And I know I think I'm on 600 milligrams.
Right. You're on a great dose.
Yes. But what did you see me in 2 weeks, or how did that work? Or you just called me and said, just take?
Yeah, I mean, and I said this in the previous show. I do a lot of check-ins with people.
Okay.
You probably have experienced that with me. So I don't have people necessarily come back in 2 weeks. I'll say, hey, try this and call me. So
Okay.
I try to do that. It saves people money. I make it very clear to patients I'm always available to talk. Don't worry, you're not bothering me. It's my job. But yeah, I like to talk in between. So I like to titrate, and then I like to say, okay, do that or stop there and then do this. So I like to do that in between visits,
Okay.
especially after the first visits. Before I see a person back, I usually talk to the person at least once or twice over the phone in between, and when I'm titrating and trying to figure it out. And I can tell very early on if someone's on the right medication or not. And if they are, like in your case, we probably started at 25, 50, and then we did 100, and then 200,
That
and then
sounds right.
300, and then we just kind of kept going up and up and up. 600 that you're on is a very, very common dose.
Okay.
I have a lot of people at 900. I have a couple people at 1200. So there's a lot of flexibility with Seroquel. But the great thing about Seroquel is sleep. It's
Yes.
an amazing medication.
Yes.
There's nothing like Seroquel for sleep quality. It's not addictive. And everyone's saying, how about Ambien or how about melatonin over the counter? That doesn't work.
It doesn't work.
And then there's other ones like benzos, like Ambien or Xanax or whatever. But they're addictive, and then people sleepwalk, and then
Oh.
and so Seroquel is amazing because there's nothing better for sleep quality than Seroquel.
Yeah.
No, and again, we got to make sure to not go so high. I mean, some people, like if I took you to 800, 900, you'd probably be like, oof, too much. You'd be too tired the next
Next
day.
morning, yeah.
So there is a point with Seroquel that okay, that's enough. But yeah, you're at a great dose of that for sure.
Yeah, the other thing I like about your book, excuse me, is that you kind of put it in layman's terms so that I can understand what you're talking about
Yeah.
instead of this medical book that's like, what is this? So I really appreciated that when I was reading it.
Yeah. Thank you. Well, on my first three books, Healing the Mind and Body, the trilogy, they're down there.
Yeah.
Those took me 12 years, and they're also for lay people. Maybe the third book gets a little bit more medical for doctors, but the first books kind of lay down the groundwork, like the science of it, the neurons, the synapses, and so I basically explained medication, how they work in my first books. This book I wanted to be different, and I wanted to share stories, like you said, and I think people can relate to storytelling. And people can, like I said, a lot of my patients say, hey, you know what? Did you write, is that story about me? And I say parts of it might, if it sounds like it might partly be you, but there's not one story that's one person in my book.
Okay.
There's maybe one story has 3 or 4 people in
Like
one
a collection.
collection of people. And so basically, but I think the storytelling has been a really good way to teach, and like you said, it's easy reading,
Yeah.
it's understandable for a layperson. And I was afraid kind of because I put a lot of medication information in the stories, and I was kind of afraid that I didn't want to bore people, and I didn't want to put too much medication information into the stories. But now I hear from people like yourself that actually it wasn't too much
Yes.
about medications. It actually was really helpful.
Yes. Yeah. Yeah. What I feel now is calm. But before I was really hyper and didn't know how to calm myself down. But the medicine that I'm on right now, really helps me to just feel calm. Because I think I was telling you earlier, I started having panic attacks. And the cause was going up and down stairs. I don't know why, but I lived in the towers in Laguna Woods, and the towers is like a hotel.
Right.
So I was on the 8th floor, and both elevators went down, so you had to use the stairs.
Oh boy.
Totally freaked me out. Then I said to myself, just calm yourself down. Why don't you just meditate before you have to use the stairs? And that helped a lot.
Well, you have MS, right?
That
So-
is correct. I have MS.
So you have to
Balance
stairs,
problems.
That's a little difficult for you.
Well,
isn't it?
and you feel bad because there's people there that are in their 90s that are on the 14th floor. Yeah, I struggle with balance, and I'm supposed to be using a walker, but I don't want to pay for one, so I have to go to Goodwill and get one.
Yeah, well, that's good. You can get one for free.
Yep,
Oh, really?
yep, that's
Oh,
why I'm going to
nice.
go. I know one of my friends told me, and I'm
That's
like,
nice,
might as well do that.
Yeah.
Who cares if it's used?
Yeah. Yeah, and I also share in the book about how I discovered. I think we were talking before we started taping about the my trip to Chicago.
Yeah,
Um,
yeah.
so in section 5 of my book, I tell my story. The title of the section is called "Why I Love My Job," um, and I kind of tell my story. So what happened with me is I started in family medicine in 1992. And I started really starting at like within a year later when the Effexor XR came out, when it was a groundbreaking discovery for me about how SSRIs were not the only medication out there, and so I started seeing amazing things happening with my patients with that, and helping anxiety, helping their physical pain, and I was blown away. Um, but then it was in 1997. I went to a lecture or a speaker training. So I was already well known in the field. So I would do speaking to primary care doctors about certain subjects. So they sent me to Chicago for training about a medication called Zyprexa, which is in the same family as Seroquel,
Mm-hmm.
just not as good. But when I was there at the conference, I was just like furiously taking notes because I was hearing of this information about bipolar disorder, and I'd never heard this before. I thought I knew what it meant, but I really didn't. I thought I was, I read the text part of the textbook about it, so I thought that was it. No, textbooks are old information often, so I
Oh,
was hearing all this new information and exciting stuff, and so I started, really understanding what bipolar disorder was and how it varies from severe to mild. I mean, some people don't have any hypomania, no mania. They just get depression, and then doctors think, oh, just give them an antidepressant. That's it. No, maybe part of it, not the whole thing though.
yeah.
So I started understanding there was like from very mild to severe, and like all this like in between, that was present, and I didn't even know that, and so when I got home, I started having my assistant here call these people in. All these people I didn't know what to do with them. I think I know now.
Yeah.
And I would put them on Zyprexa, and they would turn around. And these cases that were on antidepressants, and they were getting maybe worse, and I stopped them, or they were getting somewhat better, but they weren't getting fully better. I would add we call it atypical antipsychotic, and boom, they get better. And I was just like, oh my God, this is it. This is so that was a really significant discovery. And on the plane ride on the way home is when I started taking a bunch of notes, and that became the basis of my
Oh, really?
of the bipolar chapter in my first book. Is all the notes, this chicken scratch on the plane, and then I put that into a chapter in my book. And like I said, I really enjoy the subject because most doctors are still confused about it. The statistic that's really frightening is it takes about 7 to 10 years and 3 to 4 doctors to diagnose bipolar disorder.
Wow.
That's including psychiatrists. So
Wow.
you think that, well, wouldn't psychiatrists know? How come they don't know?
Yeah.
Well, you'd be surprised. I mean, you'd be surprised how many psychiatrists still don't get the big picture. They'll see bipolar one, the mania. They may catch the hypomania, but they don't always catch bipolar two. They don't always see the hypomania. They may not see that. They may think it's depression or anxiety and not treat it. But most doctors, here's an antidepressant, here's another one, and they're not understanding that you're beating a dead horse here. You keep doing the same thing, and you're wondering why the person's not getting better. Well, maybe you need to step back and say, wait a minute, I need to reassess the diagnosis. And very early on, the doctor should be always thinking, okay, 1 or 2 antidepressants and things aren't going right. Maybe we're dealing with bipolar disorder.
Yeah.
Even if they don't have the frequent signs, that's the time we start to think, let's try some Seroquel, let's try some Zyprexa, let's try some Abilify, let's try another way of going. But I see many psychiatrists just doing 3 or 4 SSRIs in a row, SSRI after SSRI after this, and doctors just, whether it's primary care, well, primary care doctors don't usually go that far. They usually punt and say go to psychiatrists. Even psychiatrists do the same thing over and over, not really seeing the big picture of the subject, and so that's why it's a frightening statistics that doctors are taking so long to diagnose it, and so most people with bipolar disorder are never treated, they're never recognized, And that's a sad thing is that, if you don't go to a doctor that's recognizing and know what they're doing, then you're not going to get treated and you're going to have to suffer and potentially long term, because there are a lot of these people who drop out and say, forget it, I'm done. And so some of these people who won't even go back, and they're lost to treatment. And what that means is they'll never feel better the rest of their lives. They're going to have to suffer. And that's the sad part. That's what I'm fighting against with writing, with doing the show, is I want to really destigmatize the subject and explain to people that, look, there's solutions here. You just need to go to the right doctor.
Yeah, see, I never felt stigmatized by bipolar. It's like if I have MS, why would I be like, oh my gosh, people are
Right.
going to see something about me, like she's going to, be bedridden or whatever. So I never
Right.
had a problem with the stigmatism of bipolar. But I do want to ask you something. I'm on gabapentin, and at some point somebody told me, it might have been you, told me it was an off-label for something else. So what was the something else?
Well, gabapentin is one of the medications I use for a lot of. Well, the main things it's used for. I mean, a lot of people know it for like neuralgia, like
Yes.
peripheral neuralgia. It's used for pain conditions. So so severe pain, pain and anxiety. So it's really used for pain and anxiety. So those are kind of like off-label things, but to me, off-label means cutting edge. So most of what I
Oh,
do is off-label.
wow.
So gabapentin is a very mild mood. It helps stabilize the mood. Topamax you're on. Topamax helps with pain, anxiety, and also helps with reduction of appetite a little bit. So it keeps people from gaining weight, which is nice.
Yeah.
Lamictal you're on. Seroquel you're on. So yeah, you're on a really good mix. But with off-label means using medications for reasons that the government doesn't initially grant approval of. But that doesn't. I don't care what the government thinks.
But how do you
Uh,
figure that out?
well, I figured it out just by studying and learning and doing and
Okay.
just seeing, like, because I prescribe a lot of gabapentin over many years, so I just know by experience and what's gonna by my patients, what they're telling me, and I kind of, after doing it so long, you just get good at doing it. So
Well, that's all I can think of.
yeah.
Otherwise, this is going to go on for a long, long time.
We
But
could
I
we
do.
could keep going, but yeah, but just to close up, I appreciate Kristen, you're coming in. I really appreciate this, and I want to, so many people with bipolar disorder are ashamed of them. They think, well, I don't like that diagnosis. I call it the B word. I don't like the B. I don't like it. Just call me anything else. I said, well, I'm sorry, but this is reality, and. But I think the important thing is it's something that's genetic. You get it from your family. You probably got it from mom or dad or both.
Hmm.
So it's genetically based. That means you can't help it. And so forget about the stigma. Just get treated. And like I said, if people are out there who are frustrated with their doctor, they can't get treated properly, give me a call. I mean, I'm open to seeing patients virtually even, if need be. And so again, or find someone who knows what they're doing. But there's really no reason for people, even with the most severe types of bipolar disorder, there's no reason to suffer. There's always a solution. I've not seen one patient that I've ever seen in over 30 years now with bipolar disorder that I haven't been able to fix. That's how treat, but you have to stick with it. The doctor has to stick with it. The patient has to stick with it. You got to be patient with the process, realizing it takes a little bit of trial and error, and you got to do this. But so that's why both the doctor and the patient have to really stick with it, communicate with each other, and trust each other.
Well, you've been a lifesaver for me
I really
because I
appreciate
was going around like all manic and like I said now, just calm.
And that's why I do it. And thank you for saying that. This is what really is why I love what I do. Is I love to help people. I love seeing the results. I love seeing people's lives change. Because when you change one life, you change everything. You change the family. You change the dynamics of the person, the relationships of the person. Everything gets better when you get when you get treated. So thank you for coming in. I appreciate it.
Thank you. It was my pleasure.
Okay. I hope you enjoyed the show today. If you have issues with mental health, or if you know someone who needs help, I'm available. If you want to contact my office, my website is drpaulcoronamd.com. That's DR for doctor. And you can also learn more about me on my website. My phone number, if you want to contact my office directly, is 949-481-0118. If you want to learn more about my methods and what I do, my latest book, I recommend The Corona Protocol, a scientifically proven medical solution to stop addiction, bullying, homelessness, school shootings, and suicide, 30 years in the making. In this book, I tell 30 original short stories about people. And I also have my first 3 books, Healing the Mind and Body, the trilogy, available online. I look forward to you joining me again on the next episode of the Dr. Paul Show.